gentlemen. I'm Yu-Chuan Jack Lee. I'm here to give you a short talk on the international healthcare trends in post-COVID-19 area. Actually, this is also a report on my sabbatical leave. So I was planning to do my sabbatical in 2020, but then because of what you know, COVID-19, I was so it was delayed to 2021. So in the end of April this year, I feel like we already had 200 days of COVID-19 free. No COVID cases, 200 days of zeros. So I decided, yeah, maybe it's time for me to go. So I left on the beginning of May to Boston to work with my colleagues in Harvard and Brigham and Women's Hospital for 6 months. But then, unfortunately, when I first arrived, people invited me to talk about Taiwan experience. But then, after 2 weeks, in the middle of May, we had 300 cases and then 600 cases, and suddenly, like, everybody's in a state of panicking and asking for vaccine and things like that. So, but now we've recovered. It's great to see that we've recovered and the vaccine has been the vaccination of the population has been going very well. So anyway, now we're back to almost zero local cases. So I think that we're doing a very good job. Okay. So in the several weeks ago, I was assigned the president of the International Medical Informatics Association. The former president, Dr. Sabine Koch from Sweden, she just stepped down after a 2-year term, and I pick up the position as the president of the association. It's also pronounced as IMIA. IMIA was established in 1967. It's a formal NGO, non-government organization under the WHO, based on Geneva. We used to have to go to Geneva several times a year, but of course, due to COVID-19, everything changed. We only meet online, like what we're doing now. But actually, that saved a lot of trips and a lot of money, a lot of effort. The only pity is that you don't get to see the beautiful Geneva Lake and the buildings, of all the Switzerland, beautiful sceneries. But anyway, so IMIA is the largest and the only formal international medical informatics organization, and it has more than 60 member countries. And we also had the first online world international meeting. We have a biannual meeting, meaning every 2 years we have a world meeting, and usually we have something like 2,000 to 3,000 people participating. But this will be the only virtual MedInfo, which is the name of the conference. MedInfo 21 is the only MedInfo that's purely online. There's no in-person sessions. The theme was One World, One Health, Global Partnership for Digital Innovation, and it's been quite a success. So I was able to get our Minister of Health, Dr. Chen Shizhong, to be on the same stage, the virtual stage, with the WHO Director, Dr. Tedros. Okay, and on the right lower corner, that's the Minister of Health from Argentina. So during the pandemic last year, the IMIA actually we sent a letter to WHO, and we suggested that WHO should use informatics, meaning IT and IT methods, to fight the pandemic. Okay, and the data you can actually search and find the data online. But majorly, the data address 4 different things. Preemptive AI, meaning we should be preemptive. In Taiwan, we call it 超前部署, right? So we should do 超前部署. But how do we do preemptive? We have to use AI and its predictive power. And in order to use AI, we need number 3, big data. But in order to get big data, we need to share data across the world, which is already happening. Okay. And number 2 is to encourage other countries in the world to deploy more telemedicine. You know, in the height of the pandemic, U.S. You know, since the last March, since March 2020, last year. So the pandemic started, and President Trump gave an executive order on all the health insurance companies, including the federal one, that they were gonna reimburse telemedicine like it's an in-person session. Okay, and there's no limit to how you conduct the telemedicine session. You can use telephone, you can use a video, you can use teleconference system, you can even use email. There's no limit on the form of telemedicine. And they're all reimbursable, meaning the health insurance can pay for it. So on the peak of the pandemic, the US actually replaces their outpatient visit 50% with telemedicine. Okay, now it's back to about 20%, but it started as 0.4%. So you can see the dramatic change from 0.4 to 50%. Now it's back to 20, but still, they did a large-scale questionnaire, and every patient who used it, 50% of the patient, they would like to use it again. For the doctors, 50% of the doctors, they feel comfortable using it. So this pandemic is actually an opportunity to push telemedicine forward, a giant step for telemedicine. And number 4 was transparency. Where actually the whole pandemic may be caused by one country who is not transparent, right? Because they did not tell everybody that something's happening, and they let their people go out to all the world, the rest of the world. That's why the pandemic spread so quickly. So we do need transparency, and we need it now more than ever. So after the pandemic, the future that I see in healthcare will be, there are 3 points, right? One is smart in every way, meaning we need to use AI in every process in the healthcare system, and we need to renovate. We need to innovate and renovate and change the healthcare system because it's really, really not perfect. Okay. So if we can change that, maybe we can achieve something called health from home, meaning we don't have to go to a specific place to seek for health consultation or to seek diagnosis and treatment. We can do most of the things from home. I also call it tele everything, meaning if you can do it virtually, don't do it in person. Because everybody knows now, going to a hospital is really a dangerous thing. It's probably the most dangerous thing that you can do, you know, in your daily life. And also number 3 is early and earlier for everyone. We want to be able to see disease coming. We want to be able to see any health problem coming before they become reality. And we want to do that for individuals, not for a group of people, but also for individuals. So smart in every way means we should use AI in every place in the hospital, ER, OPD, IPD, ICU, OR, radiology. Now it's mostly in radiology, right? And we should use AI in the image, and now it's mostly image. But we also should use this on text, by signal, and codes. I will show you some examples of how we use codes, AI in codes, and we're able to deal with thousands or tens of thousands of variables at the same time. And AI for patient, AI is now mostly for care providers, but we also need AI for patient and for administrators, insurers, for all the stakeholders of healthcare. If there's something that's a priority, I think AI can be used for quality and patient safety, and also anti-burnout, because the burnout 在台湾叫血汗，血汗呢 is actually a phenomenon not only in Taiwan, it's everywhere in the world. Whenever I go to an international conference, the most medical conference, the most crowded session will be one of the two topics. One, AI. The second topic will be burnout, burnout assessment. So you know how serious it is. And the reason is actually quite clear because of the aging society of the whole world. The need for healthcare has been greater than ever. And because each country doesn't have that kind of budget to provide healthcare expansion unlimitedly, so they have to push back. And they ask doctors and medical professionals to see more patients with much less pay. So the doctors and professionals are pushed to work long hours without additional pay. That's why burnout was caused, because more people would actually get out of the system. For example, in the US, after the pandemic, 500,000 medical professionals actually quitted the healthcare system. And they never want to come back because it's just too risky, too long hours, too hard, and too little money. So that's why. So it's a problem everywhere. And how do we use AI to do that? We'll see that in my following slides. So this is a very busy slide. You can see a lot of company names. Like the first one is a Fees IQ heart rhythm on the left-hand side. Respiratory module, and the company is Fees IQ. The detection of atrial fibrillation is the function. And there's a 510K pre-market, not available. These are all the cases, some of the cases that's approved by FDA. The AI in medicine cases that's approved by FDA in the past several years. There are in a total of 78 FDA-approved AI. If we look at their specialties, they're mostly in radiology. Well, as you already know, or you can imagine, because AI has a breakthrough on image recognition, so many medical AI are used in radiology. And the second largest will be cardiology, also relying on image and also signals like EEG. And there are also some ophthalmology. It's mostly about retina image or the fundoscope, 叫眼底镜，眼科的眼底镜的影像。So ophthalmology, it's also image. Psychiatry, neurology, hospital monitoring, endocrinology, pathology. Pathology is also about image. But the rest are other signals, also pediatrics. Yeah. And if we look at a secondary medical specialty, meaning radiology is the primary specialty. So, but what do you use the radiology image for? The second specialty is oncology. So use the AI used on the radiology images in order to diagnose or helping to treat cancer. So that's the most common FDA-approved AI technology in medicine. So oncology first, and emergency medicine, there are two of them, so you should add them together. The emergency medicine is also about 20%. Neurology is also about 20%. So as you can see, but we are on the beginning of a huge wave of innovation. So we're going to see many more AI medicine technology that's going to be approved by the FDA. So let me give you some example of health from home. You can do telescreening, teleconsultation, teleintervention, telemonitoring, and telesurveillance. So on my right-hand side, there's a product called Loop System. These are also FDA approved by the Palo Alto-based startup called Sprite Health. That's one wearable device that gives you pulse oximetry, respiration, heart rate, and blood pressure all together. Usually you need 4 devices to do that. Now it's just one device. Then you wear it, and it will monitor all of them. It was started it started as a COPD patient monitoring. COPD stands for chronic obstructive pulmonary disease. Things like emphysema, serious asthma that's caused by smoking, things like that. These are all in the category of COPD. So, and these are also very useful in COVID-19 patients because COVID-19 patients need to be monitored closely on their blood oxygen, which is the function of pulse oximetry. And also, the third trend is called early and earlier for everyone. So we use AI for disease prediction, AI for disease screening, monitoring, progression, microprogression, mortality, prognosis. Even we can use AI to predict disability. So it's not AI for early. It doesn't mean that it has to be before the disease. We can be early or earlier in preventing disability after the disease. So my point is that we should be earlier in healthcare every step of the way, not just before the disease. Because when you're old, you're bound to get some disease. I mean, there's nobody that's perfect forever. So there must be some functional disability. But if we can prevent the deterioration of disability, it also gives us better quality of life, and that's healthcare cost. So one of the examples for a disease screening or disease monitoring is this product called LungQ from Sirona, which is a company name. It will monitor all the chest CT scan, and it will detect emphysema, air trapping, because air should not be trapped in the lung, and airway morphology and feature completeness. I mean, if the features are not clear, that means there's some growth on top of the features. We all know that lung have 5 lobes. So that's 左耳右三, left 2 lobes on the left and 3 lobes on the right. And between the lobes, there are features. So you should be able to see the feature. If the feature are discontinuous, then something's wrong. But these are the details that sometimes people would miss. Human radiologists, because they're so busy and their workload are so huge, sometimes they will miss these things. And AI is the perfect way to make up for that and help people, help professionals, help the experts to do their job more accurately or better, in order to prevent some misdiagnosis. So if you're interested in seeing the whole list, I already put it online, and also you can reference from the paper. I think there's a paper. Yeah, the paper on my left lower corner. That's a website that actually provided all the data. I also put them in an Excel file, a Google Sheet file online, which if you're interested, this is the hyperlink. Okay, so it's not just, so AI medicine, they're not just FDA approved, but it's also available in the form of App Store. If you use Apple iPhone, then you know where to download your app. You go to App Store, right? If you use an Android cell phone, like a Google cell phone, then you go to Google Play to download your app. Also, if you use a GE imaging system, then you go to GE Healthcare App Store. They also have an App Store. There are 110 apps. So if you use a GE imaging system, you could download some of the app. Most of them are free to begin with, and then you pay later to a different company, not GE, mostly not from GE. So they create an ecosystem. This is the Epic. This is Epic App Ultra. It's like Epic is the largest provider of healthcare, of hospital information system in the U.S. Almost more than 60% of the hospitals in the U.S. are using Epic. But Epic is famously or infamously expensive, but also famously reliable and comprehensive. The hospital that I was doing my sabbatical leave, called Brigham and Women's Hospital, which is kind of the second, almost the second largest after Massachusetts General Hospital, which most of you know. So MGH is probably 200 bed more than Brigham and Women, than the BWH. So BWH was about 800 beds. They spent $180 million on purchasing the hospital information system from Epic. So 180 million 1.8亿美金, right? And 1.8亿美金 means they spend about 50亿台币, 50亿 in buying a hospital information system. Okay, 800-bed hospital. But again, since it's so reliable and so complete, I mean, the functions are very complete. So many hospitals are still using Epic. It's like 30 years ago, if you use IBM, you're safe, right? No matter how expensive IBM is, if you use IBM in your company, then you're safe. You're never, something, I mean, it can never go wrong with IBM. So Epic was like the IBM in healthcare system. All the hospital, if you use Epic, then people say, oh, okay, you're safe. So Epic has this App Ultra, it's like App Store. As you can see, there are 547 apps online that you can actually use to plug into your Epic system. So, but of course, you need to be using Epic already in order to use these plugins. But imagine you spend so much money, hundreds of millions of dollars on the system. You would not shy away from a 10,000 plugin that would help you, right? So it's really, and I'm proud to announce that one of the startup from TMU, from Taipei Medical University, we are the only company in Taiwan that has an app in the Epic App Ultra called MedGuard. Okay, and the company name is ESOP, and the company name is ESOP, and we're gonna submit another app into this Epic App Store called DX Prime. The first app called MedGuard, it's focusing on using AI to detect medication errors, and we aim at the 1.5 billion medication errors every year in the U.S. And the second plugin, we're days away from being put on the App Ultra. We're almost there. It's focusing on charting error or omission, meaning something you should put in a chart but not there. And it's a market of about 600 billion denials, meaning if you miss something in the chart, you may not get paid for your patient. That's how expensive it is. Okay, in Taiwan, our national health insurance will deny about a few, in terms of US dollar, probably $1 or $2 billion. But in the US, because their healthcare expenditure is so big, it's $3.3 trillion. So they have a 600 billion denials, and we're trying to help them. Okay, so I talked about early and earlier, and we all know that AI can help illness, major illness, minor illness, but I'm more focused, and I think the trend is more on the future to use AI, not just helping disease, but also help sub-healthy and healthy people. So I wrote a paper with my friend in MIT, Dr. Leo Selly, about earlier medicine. And early medicine is actually, you can look at it as AI plus precision prevention. Okay, so within precision medicine, there a section called precision prevention, and if we use AI in order to achieve precision prevention, then I call it earlier medicine. But if you're interested in the detail, I'm not going through the detail. If you're interested in the detail of why it's called earlier medicine and how we define it, you can look for the paper. We call it "How Can Artificial Intelligence Make Medicine More Preemptive?" So you see preemptive again. Okay, 超前部署, right? So we want to be able to be preemptive every step of the way in healthcare, right? Not just in COVID-19, but every step of the way in healthcare. So about early, several years ago, we created an app called MOMI. If you're interested in trying it, you can use the QR code here. So several years ago, we did this. And this is actually an app that will look at your nevus, your mole, and tell you the risk. Okay. So this is my son. So he has a nevus, a mole on his palm, and he said, "Oh, I Googled it, and Asian people or in Taiwan, if we have a mole or nevus on my palm or my sole, it's more dangerous. It's more risk." And I say, "Yeah, that's right. But still, it depends on the mole." So so we used the AI to look at it, and it's lower risk, and he's happy. This is another young person, young male, about 19 years old. So his mother brought him to our clinic and said, "Oh, your mommy says it's higher risk." Okay, so 你的智能达人说我们是风险较高，那怎么办? So we did a biopsy, and it's a pre-malignancy, meaning it's starting to change. It's not cancer yet, but it's starting to change. So if you look closely, there's a little whitish area in the middle. Okay, I'm not sure your screen can see that, but if you can, there's some whitish here, and this border are not actually very smooth. It's almost like a flower, you know, it's not smooth. So it's a pre-malignancy, and the mother was very happy. So she bring all her sons to for a checkup to our clinic. This is a young girl. She had a black spot, a mole on her palm near the 虎口, okay, near the place. So, and it looks really not very smooth. It's not big. It's quite small, but it looks weird. So we and she came because she used the MOMI, and MOMI told her it's a higher risk. So we did a biopsy, and it's actually malignant melanoma, but very, very early. Okay, we're fortunate that she used the app and detect her malignant melanoma in stage 0. In stage 0, we only have to cut a little bit wider, and then she's cured. But if she waited until like stage 2, stage 3, then she might need to have an amputation of the whole palm, which is very bad, I mean, for everyone. And that may not cure her, you know. So early is very important. Like this 80-year-old female, is when she came, she doesn't want to see it. She didn't want to see a doctor. All her friends tell her there's something wrong. You need to see a doctor. But she said, "Oh, I'm old enough. You know, if I die, I'm okay." So, but after all, her friend tell her to come, and she came. It's a malignant melanoma stage 4, and it's already spread to axillary lymph node, and there's nothing we can do about it. So we've promoted. So also we have a startup from TMU. We spin off a startup from TMU, and the startup has already promoted the app for about 100,000 people to use. So so that's great. So we're able to use this AI to see the difference between, you know, higher risk and lower risk. And now we have, you know, 100,000 use. So we have more than 200,000 images. Let's skip that. So So this is the paper that proved this is, so the red line is the performance of the AI, and the green triangles are the GPs. So KAs, we invited about 20, 30 GPs, the doctors that have their private practice. And their performance are pretty good. I mean, on the left upper corner, this means good performance. But the AI is a little better than most of them. And it's published in the British Journal of Dermatology, which is a very good journal in our field. There are also many examples that we predicted, like these two papers. This is from our lab. These two papers are from Harvard, in the lab from the Brigham and Women's Hospital that I work with during my sabbatical. So this is to do a prediction on drug resistance, on when the drug will become resistant. It's a paper we work with Academia Sinica. Many of you are doing the biomarker research, and lung cancer has a very effective target therapy drug in the category of EGFR TKI, or epidermal growth factor receptor tyrosine kinase. So this category has several target therapy drugs that are very effective for lung cancer, but it will become resistant after a few years. And we're predicting some patients that if we use statin in conjunction with the EGFR TKI, that would actually prolong the period before resistance. That means the patient could survive more years, without switching to a different drug, which is very useful. So we did a prediction with that. And these two papers are from, like I said, from Harvard University. This is for prediction of disease progression and prediction of disability prevention, just like I said. This is for dementia, and this one is for COPD. So we're trying to predict cancer happening in the next 12 months with about 1,600 variables. And we actually formulate patient into like images. So we can use the most breakthrough methods in AI from images. For example, if AI look at, there's some blue hues here and there's no blue here, and people with blue hues here may have more risk on cancer, and this one doesn't have more risk. So after a while, the AI would know which one is high risk, which one is not. So we published in JAMA Dermatology, which is the best, used to be the best journal of dermatology. And we use non-image information. We only use the phenotype information from medical record to predict skin cancer. And this one is the similar methodology, non-image medical record to predict the lung cancer. Okay, and this is another one. This is actually our earliest paper. We submitted this earlier, like 2 years ago, but it was published the most latest about liver cancer. Also, so we discovered that we're able to predict liver cancer, prostate cancer, colorectal cancer, breast cancer, and lung cancer in accuracy more than, it's not actually accuracy, it's AUROC, but usually we call it accuracy, more than 90%. And we were surprised to begin with, but now we know why. So for example, if we can predict lung cancer, we will be much better in terms of screening for lung cancer, because now there are two group of people. One dictates that everyone with a certain age should go through LDCT or low dose computed tomography in order to screen for lung cancer. Okay, so if you do that, every 1,000 people go through LDCT, only 160 will be positive, but out of the positive people, only 10 really with lung cancer. The other are false positive. The other 150 people, they're false positive. So you get only one true positive per 100 LDCT. You have to do 100 people to get one lung cancer, which is not very cost effective. And the other 99 people who don't have lung cancer, they pay for it and they get the radiation for nothing. It's not very useful for them. So if we use our digital screening, use the AI, we're able to capture, 9 out of 100 or 90 out of 1,000. It's 9 times more efficient. So in the future, we expect that AI could actually tell us all our disease risk. These 2 examples, but there are many more to come. And we can do this disease risk screening. We can do digital screening every couple of months if you want, because there's no radiation, there's no invasiveness, you cannot feel a pain, you don't have to go to a hospital to do it. It's all digital and tele, right? So we use all these data in the medical record. We extracted them and we call them phenotype because they're already expressed. So if imagine in the future we have all the genome, we already have a lot of genotype. Now we're also having protein, a lot of protein biomarker, proteomic type, and the micrometabolome. I mean the protein biomarker and the phenotype, the metabolome. Not there's no micro, just metabolome. And the exposure type, which is the environmental factors and the behaviors, which you can get from the wearable device, and microbiome. We know that the gut microbiome, skin microbiome, oral microbiome, they're affecting our health. So if we get all these variables, I estimate it will be less than 2 million variables. Okay, it sounds like a lot, 2 million variables, but in 5 years, our AI machine will be able to handle 2 million variables like a breakfast. So it's not really a problem. So we collect all these data from birth to now. Then we have the temporal data, meaning we have everything across the time frame. Then we're going to be able to predict all the diagnosis, all the rehabilitation, treatment, prognosis, even death. So that would actually make healthcare much more affordable. Because if we do it later, like now, the costs are higher and higher, and there are more burnout. So eventually, healthcare system has to crumble. There's no other way around. Recently, we have this Huang Dafu 院长. He said something I really appreciate. He said, 这样的健保干脆让它倒. Okay. And it's not just our health insurance, our healthcare system. It's everywhere. In the U.S., they have been predicting the collapse of healthcare system for years. Well, it has not collapsed yet, but it became a really big burden for the financial system of the whole country, even for countries like the U.S. So if we use AI plus big data, we can achieve earlier medicine, and everybody live happily after. I mean, it's lower cost, a better outcome, and much better quality of life quality, so you don't have to suffer from the later medicine, complications, and it's more sustainable. So that's my PowerPoint slide. I'm going to show you some of the photos. Let me see. Stop sharing, and then I'm going to show you some of the photos that I took, because that's why that's why we travel, right? Yeah. Okay. Can you see the photos, Christine?
Yes.
Okay. Let me see if I can do it on screen. So the first week I was in Boston, I went to this public garden, and the garden was established in 1837. It's almost like 200 years. So this is the famous Boston Public Garden, and just right beside the public garden, there's a place called Boston Common. It's also like a garden, but the Boston Common used to be, I mean, 400 years ago, they're just open grass meadow like this, and they allow everybody who lived in Boston to use this as a grazing ground, meaning they can take their sheep and their cows and their horse to this Boston Common meadow, and everybody can graze, can take the grass. I mean, eat the grass. The animals can eat the grass. So it's a common grazing ground for the animals. But now it's become a big garden. So it's like the Central Garden in New York, Central Park in New York. It's a very big. Unfortunately, there are some homeless there. It's a quite common situation in big cities in the U.S. This is the lake within the garden, and this is the famous Quincy Market. But it's mostly it's quite near the public garden and the Boston Commons. But Quincy Market is mostly a tourist attraction. I would not call it a tourist trap, but it's a tourist attraction. Local people really don't go to Quincy Market. But this is what you can get in many of the restaurants in Boston. I mean, lobster, of course, a lot of fried seafood. Actually, if you go to the supermarket, you can get a lobster, live lobster, about $10 a piece. 10块钱美金，270块台币。You can get a live lobster and they will steam the lobster for you for free. Okay, so if you're willing to wait 15 minutes, or you can call ahead. And so I usually call them and say, I'm going to pick up 2 steamed lobsters. Can you do it in 15, 20, 30 minutes? And they will usually say, sure. Then you just come and pick up 2 lobsters, and that's $20 for your dinner. I mean, for 2 people's dinner. I can only have 1 per dinner. But depends on the size. But I like lobsters. There are flowers everywhere during the spring and the summer. Even it's a little like snow in the summer, in the spring. This is the Boston Metropolitan Museum. Oh, not Metropolitan. Sorry, that's a New York. This is the Boston Museum for Fine Arts, or Museum MOFA, M-O-F-A, Museum of Fine Arts. It's got a lot. I'm not going to show you. I'm not going to bore you with the exhibitions. But if you're an impressionist lover, like if you like Monet, and Gauguin, and if you like those people, those impressionists, and also Van Gogh, Vincent, if you like them, you'll find this very satisfying. And Picasso, they have an amazing collection of Picasso. And also Monet again, because that's my favorite. They have this incredible amount of Monet and a lot of other impressionists. So I also went to New York to see the Metropolitan, the museum. That's almost like Louvre. That's comparable to Louvre in Paris, 就像罗浮宫一样. But this is a small city museum. Like Boston is less than 1 million people, probably 600,000 people. But they have the collection that's comparable to, in terms of impressionists, comparable to the Metropolitan Museum in New York and the Louvre in Paris. So during the spring, you can see a lot of ducklings from it's not even duckling, it's gooseling from the Canadian goose. Okay. And this is the Charles River. This is Charles River. And you can see on the far end, there's the Mass General Hospital. And this is the dome of the MIT. So just across the river, you see all this famous, I think the MGS is on the right, on the left-hand side. That's the dome of the MIT. And there are a lot of we even see a swan that's hatching alongside the Charles River, and a turtle accompanying the swan. The price of COVID-19 testing before I left Taiwan is 7,000 NT dollars, and in the U.S. it's only $80, like $2,000. That's the museum again. Yeah, this is one of the Monet, as you can see in the museum. I forgot what's this. Oh, yeah, we went to this place called the Cambridge Innovation Center, or CIC. It's like a co-working space. If you heard about WeWork, it's like a co-working space. For a few $100s a month, you can get a seat in this place. And this place has everything. The regular working place, you can also get a treadmill table. You can work and do your treadmill at the same time if you want. So you can browse the web and reply your email, but still running on a treadmill. And of course, all the co-working space, they will have some leisure room. You can play table tennis or video games if you want. This is one of the few hundred gardens. This is called the farmers. I mean, like 市民农园. In Taiwan, it's called 市民农园. This is for Boston citizen people live in Boston. You can apply for a small piece of land, and then you can do your own gardening. And there's a competition like every year. So every day we have to walk past this place, so it's really very enjoyable. And of course, oysters. You really need to try all the different brands of oysters. Yeah, this is the Savage Blanc. I like the Savage Blanc. It really very tasty. Anyway, but it's not cheap. I mean, each piece is about $2 to $3. So it's easily $30 count. Yeah, this is again, right. This is the Mystic River. There's a movie called Mystic River. So Mystic River is actually more on a place called Somerville in Boston. And that's where the Mass General Hospital and Brigham and Women's Hospital has a joint office called Mass General Brigham. So Mass General Hospital, which is if you don't know what that is the New England Journal Medicine Hospital. Okay. New England Journal Medicine used to be a local hospital, journal. Now it's, of course, New England Journal of Medicine. And Brigham and Women is like a little brother of Mass General. Now they combine together, and they established a compound of 4,000 people, of all the administration and all the research people are here. Like DMU is gonna have a Shuanghe science building, so most of the research people will go there. But in their case, almost all the administration people in the hospital and in the two hospitals, they also moved to this site. This is quite a distance away from the hospital. It's probably 20 minutes to 25 minutes drive to the hospital. So all the 4,000 administrative and research people of the two hospitals moved here. And this is something you have to try. It's called cannoli. Cannoli is a Jewish kind of sweets, and there's this store called Mike Pastry that they specialize on cannoli. And every time you go to Mike Pastry, there are a long line. I mean, like 200 people. It's crazy, and they have all kinds of flavors. And within the crispy like crust, these are not creams. These are cheese, light cheese with different flavors. So it's very interesting. I mean, I like it, but it will give you like the energy of a whole day. You don't have to eat anything else, and you should. This is one of the garden. I mean, one of the trail. Well, it's not even a trail. It's a trail. It's a trail in a city. They call it the Emerald Necklace of Boston. 叫做 波士顿的绿宝石项链哈，那就是像一个项链的形状，然后是一个公园，全部都是森林跟公园。And it's quite near where we stay, so I kind of walk the park all the day, all the time. This is the Boston Common or Boston Public Park during the Veterans Day. 这个是退伍军人节的时候。Oh, this is when I got there. I had an AZ shot and I got a Moderna shot. You know, I have to go to one of the place to, and you don't have to, you know, get in line. Just go to Target and there's a CVS in Target and I just get a shot. And they give you a $5 coupon so you can shop in Target. This is Professor Charles Safran. He's from Beth Israel Deaconess Hospital. Beth Israel is also a very large hospital. That's a Harvard hospital, but it's a different group from the Mass General. Beth Israel Deaconess is a different group. They're both Harvard affiliated hospital, but they're different group. Now it's called Beth Israel Deaconess Leahy. Okay, 4 different names for one hospital. So Dr. Charles Safran is a very also a professor in Harvard. He's really an inspiration. He just retired, and he has a home in Boston. Also has a home in Cape Cod. So this is my batch when I was there. And this is for people who know. This is the Blue Bottle cafe. Usually the Blue Bottle are full of people. I mean, you have a long queue. And their coffee is really something else. You need to try it. Yeah, this is my office when I was there. We're under the Division of General Internal Medicine and Primary Care. This is the office. So it used to, Mass General Brigham used to be called Partners Group. Now it's called Mass General Brigham. This is our office. That's my booth. Yeah, just a booth. This is the famous stadium, the Fenway Park. Although it's kind of a smaller stadium, but it's probably the most beautiful stadium of the whole U.S. for Major League Baseball. This was in June. And you know, when Taiwan was almost in a lockdown or level 4 quarantine, and I went to this ball game, and they were like 60% full, and no one was wearing a mask. You know, that's how the U.S. goes. You know, they were just like nothing's happening. But it's a very beautiful park. I mean, stadium for football, for baseball, and the baseball game was really something. I mean, it's like watching a bunch of Superman. And we were there for the Yankee versus Red Sox. So the local game, the local team is Red Sox, 红袜队, and the guest team is Yankee, 这个洋基队. So Yankee and Red Sox, they are like, you know, sworn enemies for more than 100 years. And they're both very excellent teams. They're class 1 teams. During the whole game, I see almost no miss. You know, 没有半点失误. It's crazy to see a game like that. It's like playing, you know, Superman playing Superman. So this is my favorite seafood restaurant in Boston. It's legal seafood. Well, there are a lot of legal seafood, but I really like legal seafood. This is the July 4th fireworks in Boston. You know, Boston is like one of the earliest city of USA, so they usually have a very big celebration for the Independence Day. That's the July 4th day, just like our Double Tenth Day, 我们的国庆日. But unfortunately, that was a rainy day, and the fireworks was set to like 9:30 in the night. It's really late. And it's really rainy, but still lots of people were there, you know, and it was late. It was said to be 9:30, but the fireworks was late for 30 minutes. But again, we had fireworks in the rain. Okay, so I would say that was worth it. Fireworks in the rain, and they used the public park. So under the fireworks is a public park in the Boston Common. Okay, so lots of people, thousands of people were there. I was there to understand, to enjoy how they celebrate 4th of July. This is my first 4th of July. This is my first fireworks in the U.S. for 4th of July. I've never been in one of the. Okay, this is the movie theater that we went to. Nobody was in the theater. It's only me and my wife. And you see this hare or a wild rabbit. You can see hare on almost on any street side, which is a good sight. I mean, I like to see the hare. Yeah. Okay. This is from Cape Cod. There's a place. This is a little bit like 台湾有一个叫什么？有一个沙滩，有个浅滩。So when the tide is rising, then everything's covered. But when the tide is low, you can walk 20 miles into the sea because it's very shallow all the way. But it's very exciting when the tide is rising. It's rising. You can see the water going very fast into the land. So you kind of have to walk very fast when it's rising. But when it's low, you can see people, like very, very far away, like 20 miles away. So this is the Mass General Brigham building in Somerville, like 25 minutes away from the hospital, but 4,000 people work here. And on this is not even weekend, this is Thursday. On Thursday evening, it's actually on every day evening, they're like celebration and their beer and kind of a party every day, nice life. But this is when I was in New York for a week. This is the not 101. This is the building after the World Trade Center collapsed. So this is the new World Trade Center building. As you can see, it's in the middle. The 一柱擎天 is very high. And the original 2 sites of the 2 World Trade Center buildings become a whole. And there's a hole within a hole. So there are 2 holes. And there's a kind of this is our artist construction for the memorial of the. It's very deep here. It's like bottomless hole, 无底洞一样. So this is one of the building, and there's 2 of them. Yeah. Okay. So back to the sequence is a little off. This is this is Mass General. So back to the Mass General Brigham building. So it's 2 hospitals: Brigham and Women's Hospital, Mass General Hospital, and this is one of their meeting rooms. As you can see, the view is quite amazing. And this is their. I hope our new Shuanghe Hospital has Shuanghe building has public space like this. Fully sunny room. It's not even a room; it's a public space. You can just sit here and relax. So I have been suggesting to President Lin that we need more public space. Yeah. So this is one of the balconies. This used to be a region of a 工业区, but now it's much better. And they even have a garden on the patio of on the 5th floor. So it's like a garden, seating garden with 空中花园. And they make it like a forest. So this is the best seating garden I've ever seen. It's really nice. Outside of the 5th floor, there's a patio and there's a. Okay, this is this is in our MedInfo 21. I also get Lloyd Jin to give us a talk in the virtual meeting. And this is you've seen this. And so one of my friends worked in the Mass General Hospital. So the Mass General Hospital has a central building and 2 side buildings. One is called Launder Building. The other one is called the Wang's building. Wang's building, they call it Wang's building. It's actually Wang, but the Wang's building is donated by Wang An Dianao, the Wang An. So we were gonna. So this is the middle, the middle building, and they're building this old one, and they're building a lot of new buildings, and there are more new buildings in the neighborhood. My friend, who's a neurologist and the chief in the Department of Neurology, Mass General Hospital. So we were visiting this place. It's called the Ether Dome. This is the first place where anesthesia was performed. 这是有史以来第一次麻醉的手术是在这边进行的。So before 1846, people just drink, before they got a surgery. But in 1846 they invented anesthesia, which they use ether to anesthetize the patient and before they have a surgery. So this is the place. And the Egypt, they donated some monies for them to dissect. It's a very interesting place, a very small seat and very steep, construction. So if you fall asleep, you will actually fall down and then, all the way down to the floor. So this is called Ether Dome in the Mass General Hospital. This is the mummies, and this is the human skeleton. And this is the original back building of the Massachusetts General Hospital. Now it's within the kind of a garden. Okay, so these are all Mass General. This looks like a museum, but it's actually Mass General. So this is Wang An and his wife, who donated the building many years ago. Yeah, the Ether Dome. I almost cannot fit in the seat because anyway. So the rest are all tourists. Oh, this is Motif 1. This is a building called a house. Well, it's a fishing house, but it's called Motif number 1. It's the most painted building in the U.S. So if you Google Motif number 1, you will see a lot of paintings. So this is in Brigham and Women's Hospital. I'm talking to Dr. Abraham from the internal medicine. This is Dr. Habi from Taiwan. Okay, these are my last slides. This is the USS Constitution, a Navy boat constructed in Boston. This is the largest boat constructed in Boston back in 1795. In China, 那时候是嘉庆皇帝的时候, and they've already had this kind of Navy boat, and it successfully won a lot of war with the UK, Navy boats. Oh, this is last one. This is called JP Licks, the best homemade ice cream in Boston. Okay, that would conclude my talk. Any questions or comments? Christine? Okay, before we end, I would like to ask for you to turn on your camera so we can have a photo together. Okay? Can you do that? All right, great. Of course, if you're decent, if you did not wear anything, you don't have to turn on the camera. But if you want, you can. Great, I can see everyone. Wow, it's been a long time to see all of you. Okay, the rest of the people, can you turn on your camera? All right, we have okay, 10 more seconds. We're gonna take a photo together. I see some people here. Okay. Peggy, okay, I see Peggy. Yeah, all right. I see Polly. I see a lot of colleagues from the College of Medical Science and Technology. Okay. Okay, I think we almost have a full screen of people. You can actually change the size of the video so you can accommodate more people in the page, right? All right. 3, 2, 1. Okay, that's photo number 1. And 3, 2, 1. That's photo number 2. And that's it. 2 photos are enough. I'm going to send the photo back to the to Peggy and Christine. So if you're interested, Christine can post it to the wherever you like. Okay. All right.
好，谢谢大家。
Okay. I think the time is up. 谢谢大家。Thank you.
谢谢大家，拜拜。
Bye.
谢谢院长。